It's generally known that Sveti is the first refractive center in Serbia where a doctor with 10 years experience then started to work. How can your patients get rid of diopter? 9 or 10 years ago, we formed the first refractive center in these areas, and we started to perform diopter corrections with laser, as well as the corrections of high diopter values with appropriate implants. Now, we've had 10 years of continuous work with extraordinary result. It should be pointed out that this method has been introduced in this country by Professor Pavel Rozival, who is one of the leading names in the field of refractive surgery. In this way, we've introduced contemporary attitudes and a surgical and laser approach. At the moment we started to perform refractive surgery, Professor Rozival had already had 10 years experience in laser procedures. This is very important for the patient's safety. Therefore, it's important that there's a surgeon who knows the procedure well, who's mastered this procedure, and who's acquired experience after a number of years. The place where the patient is continuously monitored is also very important. It isn't convenient to undergo the procedure somewhere in the world and come back to the country where the attitudes are not the same and where there isn't a principle related to further monitoring and further contacts. Therefore, this is an elaborated doctrine, a laser or another refractive procedure, and continuous monitoring. Does myopia come back after the intervention in patients with diopter values of -5, -6? After the laser intervention and with the values of stated, no. However, there are some requirements here. If a person with a -5 diopter value of myopia has unstable diopter and says that, for example, it was -4 a year ago, while now it's -5, you can't expect that the laser intervention will stop such an increasing trend. If laser is applied at the moment when a diopter value is unstable, the diopter value will continue to change in the same manner it would change if the patient wore contact lenses or glasses. People believe that diopter value can come back. However, it's been precisely defined when this can happen. When higher diopter values are concerned, such as -8, -9, or up to -10, those corneas are indeed unstable, and you can expect here a minimum outstanding diopter value of -1 or -1.5 a year after the laser procedure. However, if stable diopter values are concerned, if the patient doesn't have any accompanying disease or hormone imbalance, the refractive result will be stable after the laser intervention. How can patients with high diopter values solve their problems? If we talk about myopia, high diopter values above -10 or presbyopia with +2 or +2.5 diopter values with an accompanying cylinder aren't for laser correction, but there's another part of refractive surgery, the so-called implant surgery. There's a difference here. In younger patients up to the age of 40, in those with preserved accommodation, or in those who still use reading glasses, we correct such diopter value for distance vision by incorporating an appropriate implant that can simultaneously correct astigmatism. Well, high diopter values and astigmatism. These are values that may reach even 7 diopters of cylinder. You must admit that this is a fascinating possibility offered by refractive surgery because such patients can't find any other satisfactory solution either with contact lenses or with glasses. Therefore, refractive surgery here fills voids that can't be solved with conventional aids. As far as patients over 40 years of age are concerned, who need reading glasses in addition to glasses for distant vision that they have been wearing all their lives, we use another surgical procedure, the replacement of own lens with the aqualace method, whereby through a small incision we perform the aspiration of the existing lens and implant a small foldable lens that can solve the problem regardless of the diopter value. Even the problem of astigmatism can be solved, for example, plus or minus 3 up to 4, with the so-called PC toric lenses that are implanted in the posterior chamber and that can simultaneously correct the cylinder problem. These are new possibilities of refractive surgery which may be closely connected with cataract surgery, and this is something that wasn't possible earlier. And this is the culmination of refractive surgery that we apply here. There's also a possibility of choosing a multifocal implant that will enable the correction of vision at near and far distances without glasses, regardless of whether the patient also has cataract or only a diopter problem that he wants to solve. I suppose all parents would like to hear how cataract in small children can be solved. Here, we mustn't waste time. We must react immediately if we assess that the intensity and location of cataract are such that they will disturb the future development of visual function. It's essential not to be late and not to wait until the child starts going to school. As far as I can see, there are many misconceptions related to this problem. What do we do in such a case? First, the operation is also performed through a small incision and, as far as children are concerned, in general anesthesia. A foldable lens is implanted, and thus the development of visual function is enabled with some correction with glasses, but these will in no way be heavy spectacles with heavy glass as it used to be earlier. Well, the child should be given a chance to start going to school one day undisturbed and having equal opportunities with other children. But cataract operation is a prerequisite for the development of visual function. What follows is further strobological monitoring, control examinations by an ophthalmologist, occlusion of the better eye in order to stimulate the weaker eye to see and develop vision function. Today, as you can see, there are also possibilities to implant multifocal lenses in children, thus providing a chance to avoid later corrections of vision either at near or far distances, as with the removal of cataract in children, the function of accommodation that enables reading without glasses is lost. However, we don't use multifocals in the youngest children. We assess whether the child has any satisfactory visual function, and then, at 4 to 5 years of age, we can perform cataract surgery with multifocal implants.
Procenimo da dete ima nekakvu zadovoljavajuću vidnu funkciju i negde sa 4-5 godina života možemo uraditi i operaciju katarakte sa multifokalnim implantima.